Um, we just want to make everybody aware that all microphones have been muted and webcams are disabled. There are two routes for communication this evening. If you have a question, we do request that you utilize the Q&A option, and for comments, utilizing the chat box. So we'd like to welcome everybody to our third annual Midwest Emergency Department Hospital EMSC PEC Symposium. Thank you for participating. We want you to know that this symposium was developed to specifically meet the needs of our hospital-based providers. We're excited to share a great lineup of speakers this evening and hope that you find them informative. We also want to thank you ahead of time for all that you do for children and their families in our community. Before our presenters start, we did want to provide a brief overview for those not aware of EMSC, which stands for Emergency Medical Services for Children. EMSC is a federally funded program authorized by Congress to provide emergency care for children in pre-hospital and hospital settings. Every state and U.S. territory has an EMSC program and collaborates with emergency medicine partners to meet the EMSC national performance measures. The mission of Emergency Medical Services for Children is to reduce child and youth mortality and morbidity resulting from severe illness or trauma. We work to ensure that all children, no matter where they live or travel, encounter health systems that are able to provide quality emergency care services. Listed on the slide is a group of states that work together with our EMSC programs and collaborate to make the Midwest EMSC Pediatric Symposium possible. And we also work to keep it free for our attendees. As listed on the slide are each of the states. One of the key components to pediatric readiness is having a pediatric champion or pediatric emergency care coordinator, a PEC. This is an individual at an EMS agency or emergency department that is an advocate for children, and they participate in activities such as overseeing pediatric quality improvement, collaborating with emergency medical services and emergency department to improve pediatric care, developing and reviewing pediatric policies, amongst other things. Additionally, a PEDS champion or PEC serves as a contact between the emergency department and the pre-hospital agencies and your state EMSC program so that you can bring back information and resources to your agencies or hospitals. To learn more about becoming a pediatric champion or PEC, please reach out to your EMSC program manager. We have them listed here on this slide, so please take a screenshot now, but please note if you miss it, we'll have it again for you at the end. We are grateful to have partnered with Children's Minnesota to offer 4 AMA PRA Category 1 credits for physicians and 4 ANCC nursing contact hours. Please take a moment to review additional accreditation information from Children's Minnesota. We do want to make you aware of a few reminders. Your attendance does not automatically grant credit. To claim credit and print your certificate, you will need to follow the course outline to complete your evaluation. This will become available once the Zoom session has ended. Credit is tied to the completion of your course evaluation. This evaluation must be done within 30 days of the conclusion of this event, and the course itself closes after 30 days with no access after that time. All of your courses will stay listed as pending activities until you have completed the evaluation and claimed your credit. Your individual certificates can be found in your completed activities by clicking on the download button shown in the table for each activity. Lastly, we wanted to share our standard faculty disclosure announcement. Our planning committee and presenters have no relevant financial relationships to disclose. Please ask us if you have any questions about these disclaimers, disclosures, and/or accreditation information. So to start us off tonight, we are extremely pleased to introduce our first speaker, Krystle Bartley. She will be presenting a quality improvement overview and discuss pediatric interfacility transfer guidelines. Krystle Bartley earned a Bachelor of Science in Psychology from Xavier University of Louisiana and attained her master's degree at the University of Houston, Clear Lake. Her work in quality improvement began in the Quality and Safety Department of Pediatrics at Dell Medical School. Krystle has expertise in the development and implementation of quality improvement collaboratives, specifically focused on pediatric care for the state of Texas and nationally. She has a special niche in developing balanced scorecards using the Delphi process. Her affiliation with Emergency Medical Services for Children began in 2016 with the launch of the Pediatric Facility Recognition Collaborative, and it continues still today with targeted work of the National Pediatric Readiness Quality Initiative. Krystle's objectives today are listed in the slide, but for awareness, it is to explain the model for improvement, identify quality measures and track performance, describe intervention strategies that can influence improvements, and identify strategies that contribute to the sustainability of improvement efforts. I will stop sharing at this time, and Krystle will take over and share her presentation.
All right, so I'm going to start my slides for this evening. Thank you for having me. I come from the Lone Star State deep in Texas. And so good luck to everyone that's experiencing some of that cold weather up north. We send our empathy to you from here in Texas, where it's a balmy 65, 70 today. So, as we mentioned, our goal today is really to talk about quality improvement and what some of those opportunities are for implementing the work in your ED setting. And so, my approach for you today is not to give the historical context. We've all heard of the stories about the founders of QI, but let's think about some of the tangible ways that we can use some of these systematic approaches to improve what's happening at our bedside. And so we'll start with this context. Here's what we know, that most kids with an emergency encounter are seen at hospitals that see fewer than 15 kids a day. So that means they're not going to the big children's hospitals, but they're going to their community hospitals or their rural hospitals, right? And we know that nearly 350,000 kids are transferred from hospital to hospital every year. And that transfer process can be riddled with complications. Everything from there not being enough beds at the receiving site to not having the appropriate contact at the receiving site for whatever reason. There could be issues with the diagnosis and just other delays in care. The research that's been done with the Pediatric Readiness Survey has shown us that if a site has a QI plan, that there's a 26-point increase in their score. And we know that that score is tied to improved survival rates. So the thought is, let's teach folks quality improvement. And I know that that's a loaded topic, a loaded question, and everyone says, oh, it's going to be a lot of work. But hopefully today we can sort of digest that into something that's more meaningful pieces that you can carry out at your current site. And so here's some of our common experiences. We've heard nurses tell us they have a hunch that if they do X, Y, Z, they know that we can improve care. We know with even maybe from firsthand experiences that there may be delays in transporting a child to high level care because we've been sitting with that child for the last couple of hours. We may even hear that term commonly, our numbers, our times are bad. But what is bad and where do we currently stand at our site? We've heard that at our previous facility, we were more efficient in some of the processes that we had in place. Or it's the classic comment that's the hallmark of the work that we do. And it's the question, are we providing the best care for this child at this time? So then the question is, then what? So the work can happen in grassroots efforts, right? Are we implementing change one by one? Is there that lone soldier that's on service during the holidays and that's like, let me document something a certain way? I'm anticipating that we're going to have certain patients in. How do we prepare? Does it come from a top down mandate? So it's hospital administration, it's the network that's saying, these are the areas that we want to improve, and these are the strategies that we want you to use. But we always sort of love the approach that's the bottom up. What's happening at the bedside? What's the care team telling us needs to be done to make the most improvements. And we think that if we can do that in a systematic way from the bottom up, everyone wins. And we call these people our implementers, our early adopters, our change catalysts. And so, of course, I have to give you your formal definition. So if you go to CMS's website, you'll see that quality is defined there by the National Academy of Medicine. And it says it's the degree to which health services for individuals and populations increases the likelihood of health outcomes and are consistent with current professional knowledge. Quality improvement is defined as this sort of framework that is used to systematically improve care. So we don't arbitrarily do the work, but we take a series of steps strategically to pursue an intended outcome. And it seeks to standardize our processes and our structures. The goal is to reduce variation and achieve those predictable results and improve our patients, the healthcare system, and the organizations where we work. And it's interesting because earlier this year, there is a group of stakeholders from the Emergency Medical Services for Children, the Emergency Nurses Association, as well as the Society for Trauma Nurses, that compiled a brand new interfacility transfer guide specifically for pediatrics. And that's where the rubber meets the road, because anyone can go online and find sort of best practices for transfers. But this group really came together and say, how do we systematically do that for the pediatric population? And their body of work addresses care from planning and preparation all the way to execution of the transfer to follow-up feedback. And I think that's the uniqueness of the product that they've created. You'll notice that they have several sections in their IFT guideline, and it talks about the types and examples of agreements. They give you some sort of interesting tidbits about how to draft and implement your agreement. So let's say your site has had a protocol or procedure in place for years, but it hasn't been updated. This is the ideal time to make that change. It's December. We're starting a new year. The new guidelines were released in July. This gives you an opportunity to say, hey, we have some nationally endorsed content that we'd like to integrate into practice this upcoming year. And so it takes into account some regulations and standards. And you'll also need to consider what's happening in sort of your jurisdiction and make accommodations for that. But there's talking points about how to garner support with leadership. How do you start having the discussions to say, we need to update our agreements? This is our sister site that we typically transfer our kids to. How do we start new discussions about what we want that collaborative relationship to be like? You'll also have some components related to the clinical process. So one of the drawbacks to previous versions of IFT guidelines was that it did not sort of consider the patient severity. And so what you'll find in this newest version is that it will look at the patient severity and then give you some recommendations about what to consider based on the patient's triage level. It also gives you sort of a timeline about how to consider what's the best transport method and the staffing that needs to be available for it. And the one piece that we are sort of remiss, but we have to keep in mind, is the patient and family-centered element. These families are now being told that, hey, you did a good job, you got your child here, but guess what? We need some additional resources and we need to go elsewhere. The beauty of this new toolkit is that it considers the patient and family. So is it that we need to provide the families with some sort of packet that says, okay, this is where you're going, this is what to expect when you arrive, these are hotels nearby. It may even include that in your own personal policy that there's a nurse that's helped even with getting a map from location to location, right? There is considerations for special patient populations because we know that we have kids with special needs and that they have some medical complexities that require extra consideration. And then we integrated this quality improvement piece. So there should always be this reflection of, are we doing the right thing? And how do we sort of maximize on our previous experiences? And then they also included case studies. So they make sure that you do your homework. Some of the types of interfacility transfer agreements you see listed here is your generic patient transfer agreement. And I would assume that a lot of you have just a basic one that outlines sort of what support is readily available at your site and when you decide that it's time to send that patient out. The guideline that's provided by the entities that I mentioned is very pediatric specific, and it talks about what resources are needed based on the patient's severity. And some of the common elements that you'll find even across both of these is roles and responsibilities and the expectations for the sending site and the receiving institution. You'll see some of the administrative policies that should be considered when you're starting this agreement with a new site, possibly. It talks about the issues of patient populations, what necessitates a transfer, even pre-transfer consultation agreements, right? Like I can vividly remember when we had the, what did we call it? It was like the triple demic. It was COVID, RSV, and flu. And sites were like, we don't have enough beds. What do we do? And there were literally sites that would get on the phone and say, this is what my capacity is today. So if you have a kid that's coming in at this level of severity, we have to discuss what our plans will be. And so those are some of the things that you'll have in place, is to talk about what sort of pre-work is done to prepare for future scenarios. And then also, as I mentioned, relevant local, state, and federal regulations. We always talk about our key stakeholders. And so in this guideline, what you're going to see is that they have a list of who should be at the table for the referring facility and who should be there for the receiving facility. And our hope is that there's 360 communication, that there's discussion between providers on both sides once the transfer occurs and post-transfer. So what's the disposition? It would be ideal if we find out, where did we miss the mark? What could we have done better? It may be that you're establishing a partnership for education that says, when you send a kid to us, this is what we'd like to see. Here's a pathway or a workflow that's ideal for a patient that's in respiratory distress. And so this is a sort of a quick snapshot of the individuals that we are promoting that should be at the table. And then those steps to create the agreement, you'll see those listed here. And I've highlighted a couple of those boxes because it relates to quality improvement. So some of the work that we have to do is really about reflection. So what's our current transfer practice? Have we been doing the same thing for years and not really sort of optimizing our workflows, but just going with the flow? And we need to look at what our data points are to see where we have gaps, where we have deficiencies. There's always an influx of new regulations that we need to consider. And so we have to incorporate those into our standards and then identify sort of our opportunities for improvement, follow up with our receiving facilities. Most of you all are not using that one particular site, but you have a list that you run through in the event that you have a particular patient, whether it's a patient that has a traumatic brain injury, or if it's a patient that has a burn, and you know where to go. And so the goal is to find ways for us to reestablish those partnerships, educate our staff, and really have those talking points for how we proceed in the future. Here's a snapshot of just some of the content that's available in the interfacility guideline. And it literally lists by the patient sort of level of severity what you should consider for their mode of transportation. And of course, these are recommendations, and you will make accommodations based on that. But you'll see here that even it goes to what are the urgent needs of the patient and consider the amount of time for travel. And so we'll make these the guideline available for you to do more of an in-depth view of the resources that are there. So then the next question for us is, how do we transition from guidelines that are newly established or best practices to implementation? And this is where we get to the quality improvement piece. And so you'll hear us commonly ask ourselves in the QI world 3 questions. What are we trying to improve, or what are we trying to accomplish? How will we know that the change that we're making is an actual improvement? And then what change can we make that will result in the improvement? And then, of course, we always say, what's the PDSA cycle? And so the next series of slides are going to walk us through some of the elements that you need to consider as you're doing the systematic process. And so let's say you're like, okay, Krystle, we have a new toolkit that's available. Our site has not sort of refreshed our process, and it's not PD specific. So let's see what we can do. And so it all starts with your team. And as our presentation started earlier today, it starts with the PEC. Let's have that individual at the table that has a very pediatric centric focus to start helping guide those discussions. It never hurts to have that trauma manager there, your charge nurse who knows how the system runs through and through, ED leadership, because you always need that C-suite and leadership buy-in. I'd say we all aren't fortunate to have quality and safety specialists, but if you have one, that's the prime time to get them involved. And then there are going to be those early adopters, those individuals that are like, I've got that hunch that if we do XYZ, we can make it better. Those are the folks to get at the table to start sort of integrating these new ideas. And as I mentioned, as you see here, the referring facility, you have a list of folks to consider, as well as the receiving facility. And so pre-work. So we don't want you just to go in and say, we're going to use a new worksheet, and for every kid that comes in and needs transfers, we're going to fill this out and we're going to send it over. No, 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 no. Start with the baseline work, right? Think about what's currently happening in your environment. And we want you to be observer. That you sometimes hear it called walking the floor, where you look at your internal criteria for transfers. Is it, and I've been saying this word a lot, but is it based on the hunch of the provider? Or is there a criteria that appears in your EMR that says this patient meets criteria for transfer based on the resources that we currently have available? I want you to consider sort of the designated modes of transfer that you have based on the patient's severity. Here's a thought too. Have you looked at your metrics? And we're going to talk more about metrics. But think about what's our time from when they hit the door in triage to when we actually transport them. And is that an opportunity for us to make improvements? And think about some of the common delays. Is it always weather? Is it that there are space issues at our receiving facility? Is it that we have delays in our diagnostics section that's sort of keeping us from moving those kids out sooner? And think about transport times. What does it look like from departure to arrival? Of course, we can't control that piece all the time, but it could be that we need to partner with our EMS providers and our transport providers to see how can we make these things more efficient and give them what they need to make the next best steps. And so some of the quality improvement tools that we use during these discussions for that pre-work is a fishbone diagram. And it literally looks like a fish. We also hear it called cause and effect analysis, or an Ishikawa diagram. And it gives you a chance to visualize deficiencies in your healthcare system. And let me tell you why I love this tool. It's always easier for the care team to tell you what is wrong with the system before you sort of pivot their approach to figure out what's right and how do we optimize that. And so this fishbone diagram is a brainstorming tool, and it helps sort of break down some of the deficiencies so that you can sort of see it as a cause and effect. So you'll see here, it gives the team a chance to literally scribble on a whiteboard What are our equipment issues? What are our process issues with our transports? Let's think about people. Is it staffing that's a reason for delays in our transfers? Materials, environment, management? It's really an opportunity for you to look at the total landscape of the care that's being provided in your ED and say, we know what our problems are, and now how do we move forward? The other tool that you, I'm sure that you have them plastered all over your your ED, or they are in your EMR, or you have seen them more times than you'd like, is process maps. But here's the twist with the process map. We always see what the ideal process is, but it could be quite sort of transformative if we stop and look at what's our ideal transfer process and then start looking at, but what's actually happening. And so here I know it's a little blurry and some of the sections may be cut off, but it could be that you add timestamps to your current workflow to say, this is where the gap is happening. It's happening when we're trying to identify the receiving center. It's happening when we don't have a packet for the family. And so the family refuses to leave until they know what's happening next, right? And so that might be what drives your improvement efforts. And so these are two tools that you may consider adopting as you are thinking about your quality improvement journey. And so remember, I asked the question in the beginning, what are we trying to accomplish? And it starts with your aim statement. And you've heard this phrase, it should be SMART. When you are working on quality improvement, you want something that's tangible. So be very specific in the work that you're doing. It should be measurable. It should be realistic, right? Like, let's not say we want to have all of our kids out that need transfers within 1 hour. That's unrealistic, right? But think about what is relevant in your current environment and add times when it seems reasonable. And so here's a snapshot of when we always say, let me show you what a SMART aim is. We think you should still have the global aim. And so an example of that could be that you have some handoff process that ensures patient safety, workflow efficiency, and patient and physician satisfaction. But your SMART aim could be very, very specific, or it should be very specific, where it's saying that by doing an intervention on the system, we will change some part or all of the system, which will result in these outcomes. And that will ultimately be your metrics. And so there are teams actually with the EMS Innovation Improvement Center that can help you with this. So you can say, we want to do this work. We know what our baseline numbers are, but where do we start? And we always say with quality improvement, go with quick wins first. We want to sort of get the approval of our teams and let them know, hey, we can do this. So let's be reasonable about sort of where you start. So then the next question is, well, how will we know that the changes that we're making is actually an improvement? And there's a sort of a great sort of tidbit that I found from a physician that's out of CHOP, and he says, without data, you don't know if you have a problem, you don't know if you're making any headway in solving that problem, and you don't know whether the intervention that you're trying to test or implementing is holding. And so that's where we get with measures. And so, as my predecessor mentioned, I love metrics. It's the easy thing. It's like your report card. Are we doing what we're supposed to do? And so we use these terms interchangeably. You'll hear us say metrics, measures, quality measures, key performance indicators. It's all the same thing. It's literally our ruler. It's our way of saying that we're going to use this certain sort of strategy to measure our healthcare process, our outcomes, our patient perceptions, the organization in which we're providing care, and also looking at the entire sort of system. And are we meeting sort of our quality goals, that we're providing care that is timely, safe, effective, efficient, equitable, patient-centered. And so this is where I will do my historical sort of piece. I know I told you guys I wouldn't do it, but I still have to drop at least one slide. The very basis of our measurement is based on this Donna Bedian model. And so we have classically three types of measures: structural measures, process measures, and outcome measures. Now, our structural measures are typically giving us an idea of where care is being provided and high level view of the system. So it's giving us characteristics of the institution, the provider, the patient. So what's our nurse to patient ratio? What's the hospital size? Are all of our physicians boarded through the American Board of Pediatrics or American Board of Family Medicine, right? It's those sort of high level things. We use that at the very beginning of quality improvement. So it could be that it's like, do we have a pediatric specific IFT guideline in place, a policy or procedure in place? And that's a yes or no. Once we do that, it's over. We then move to the process piece. And this is really where the rubber meets the road, right? It's like, tell me about our treatments. Tell me about the stages of care, the appropriateness of the care that we're providing. Are we adhering to the use of certain procedures and staying away from those that are considered not evidence-based, right? And then ultimately, we all want to get to those outcome measures. And those typically are harder to get to. But we see things like death, adverse events, readmission rates, quality of life. Those are the things that we really want to impact. And over time in quality improvement, our goal is to be able to measure these aspects of care. So I have to shamelessly plug, although Margot did mention to me that she wanted to hear more about our data platform and to include it in today's discussion, but there's a resource that's available to you. So we aren't sending you, and I say we as the EIC HRSA is not sending you out to do quality improvement for pediatrics without giving you a resource that's available. And I'm so proud to announce that we have that resource. It's called the National Pediatric Readiness Quality Initiative. And our goal is really to help sites do meaningful work to measure the quality of care that they're providing at the bedside, give them a platform to be able to reflect on that work over time, and ultimately improve the care that they're providing. It's a free self-paced platform that gives you the ability to even benchmark your performance against your peers. And when I say peers, I don't mean another sort of children's hospital. I mean to benchmark yourself against peers that see the same ED volumes as you. So it's literally apples and apples versus apples and mangoes. Um, we provide sort of a framework to help folks do continuous quality improvement, and it's designed for frontline staff. It's not an administrative sort of database. And the beauty of this data platform is that it looks at all pediatric patients, all comers. So we start with just the general assessment of the patient, and we look at the patient questions related to their assessment, the diagnostics element of their visit, the interventions that you've imposed, and their disposition. And we have kept in mind that a lot of sites don't see kids. As I mentioned, most sites see less than 15 kids a day. So we wanted something that would be very manageable for them to enter data. And so the thought is that we're not going to ask you what's the patient blood pressure. We're not going to ask you to give us O2 stats. No, we're asking, did you capture a blood pressure? Did you measure the child's weight in kilograms? Did you document it in kilograms? We are asking yes or no questions, but I'll also show you how we've translated those very simple questions into meaningful measures. This sort of data platform is part of a bigger initiative by individuals across the continuum of care. So we had hospital networks at the table with us, helping us decide what these quality measures were. We had Joint Commission there. We had safety entities. We had members of HRSA, members of the EIC, subject matter experts, you name it. They sat with us and said, how do we sort of find the most meaningful measures for pediatric patients? And so you'll see here that these are the bundles that we have available. Assessment, interfacility transfer, which is applicable to us today. We also have a blunt head trauma, seizure, respiratory complaints, vomiting, and suicidality. And so we have measures that are specific to each of those. But for today's discussion, here's a snapshot of what you would get on your dashboard if you decided to just pursue work on interfacility transfers. And it all starts with the assessment. So we're looking at weight in kilos, was pain assessed for your patients, the median ED length of stay, and then you have a new section that's abnormal vital signs. So we want to know, did you reassess the patient's vital signs, especially if they were high acuity? What was the median time from triage to first intervention? And that first intervention could be anywhere from airway intervention to medication. And then you'll see we have 3 measures related to transfers. So we'd love to know which of your patients that you transferred actually met your site's criteria. We even look at the median time from triage to transport, which is a very meaningful metric when you're doing this work. And then those number of patients that were discharged from the receiving ED. Here's a snapshot of what that dashboard would look like. So imagine you say, I'm going to start doing this work. I have my policy, my updated policy or procedure in place. This is the tool that you need to do the quality work. And so what you'll do is be able to look at your performance over time, but it also has the ability to stratify your patient data. So you can actually look at age categories. You can look at the patient's triage level and say, are we doing better with our length of stay for our sort of higher acuity versus our lower acuity? You can ask all these questions. It stratifies based on ethnicity, race, gender, and even payer source. And so we love this ability to slice and dice data. But one of the things that a lot of our groups are loving is this ability to say, how do we rank against our peers? And so here's a snapshot of those measures that I mentioned. And you'll see your performance in this graph view or table view. You'll see the national performance. And so that's the big picture. It's everyone that's sitting at the table with us. And then you'll see the cohort performance. And that's specifically based on your ED volume. So you'll be able to tell your ED administrators, for hospitals that see the same number of kids as we do, this is how we fare to them. And as I mentioned, this resource is for our frontline nurses and clinicians. It requires no QI expertise and no C-suite resources or funding is required. When we started this work in about 2022, 2023, to now, we have 106 emergency departments that are currently engaged. That's across 27 states. And as of last night, when I was working on these slides, we had nearly 16,000 patients entered into this database. And that's remarkable because that means that's that many kids that we're evaluating the quality of care that we're providing. And when I took sort of some snapshots, you'll notice that some of your states here, you have hospitals that are doing this work. And so I'd encourage you to reach out to your peers, your current site to get more involved. And so I'm going to fast forward to that last question of what change can we make that will result in improvement? And so one of the resources that we use is a key driver diagram. This is a way for us to visualize the changes that we're considering making. And so it's like we have our aim statement. The key drivers are the what. And so what are the things that we can do to improve care? We can change our policies and procedures. It could be that we're educating our care team on our transfer processes. It could be that 360 communication that we discussed earlier, the patient and family engagement, or it could be that we're making changes to our EMR. And we know that that last one is a little difficult, but it might be a stretch goal that over time, when you show improvements in your numbers, you can garner support to make optimizations in your EMR. And so lastly, the big piece that we do are PDSA cycles, right? It's this continuous sort of iterative cycle of work where we're making small changes. Does it work? If it works, let's make the sort of hardwire it, and then let's take it to the next level. And so it's all about planning, trying, observing the results, and acting on what we've learned. The plan phase is literally what it says, is that you will set up a strategy, think about what you want to do for data collection, think about the prediction. What do you think is going to happen if you put out a new worksheet or you implement this new policy? Um, if you send a blast email to the staff saying this is what our new criteria is, what's going to happen when that next transfer comes in? And so you're going to develop this strategy, and we say start small. Don't go with the really big initiative, but start small and see where you go there. And so then during the do phase, what you'll do is execute that plan, document what's happening, make your observations, and then start your analysis. Study is where we're looking at the metrics. And it would be great if you use the NPRQI platform, because we are literally giving you a real-time dashboard. Real time as in you submit your data and 24 hours later, your dashboard will be updated to reflect what performance looks like. We ask that you compare that data to your predictions and then think about really how do you want to act next. And there are three pieces to this. You either adopt the change that you proposed, you adapt that change based on your observations, or you abandon that change and consider an entirely new initiative. Um, and we say it keeps going. You continuously sort of keep this process until you reach your goals. One of the things that's available to you in that IFT bundle is that they give you a couple tools which should help you do this QI work. And it includes, and these are some small screenshots, so I apologize to you guys for this, but it gives you the opportunity to sort of look at what were your reasons for transfer, what was the efficiency in our process. It also gives you a form to start the communication between the sending and receiving facility. So what will ideally happen is that you'll connect with the physician or care team at your referring or receiving center and provide them feedback so that they'll know, hey, these were opportunities for improvement. This is what we said was the final diagnosis based on even what your initial diagnosis when we received them, and give you some information about the patient's disposition. Because isn't it nice to know what happened to that kid that came in on Thanksgiving and how could we have done something better? And so with that being said, I'm going to, come on, give you something to put in your professional toolbox. So here's a couple of links. We're going to make these available to you following today's session. But the IHI, the Institute for Healthcare Improvement, is our go-to source for all things QI. Here's a link also to access the NPR QI registration. And then we'll also make that transfer guideline available to you. So thanks for having me this evening. And hopefully if you have any questions, throw them in that chat box and I will stop sharing my screen and pass it off to my peers.
Thank you so much, Krystle. We do have time. If anybody has a question, please feel free to put it in the Q&A. Raise your hand and we will, or raise your hand and we will address your questions. Okay. All right. Moving on. We would love to welcome our next guests. We are joined this evening by Dr. Joy Koopmans and Dr. Jacqueline Corboy. Dr. Koopmans completed medical school at the University of Iowa before attending pediatric residency at the University of Chicago Comer Children's Hospital. She completed her fellowship in pediatric emergency medicine at Northwestern University's McGaw School of Medicine at the Ann and Robert H. Lurie Children's Hospital of Chicago. Since graduation, she has worked for Lurie as a pediatric emergency medicine attending physician, primarily at their Northwestern Medicine Central DuPage Hospital outreach site, but also maintaining additional shifts at the main hospital at Lurie. She is a member of both the Child Protection Team and the Emergency Medicine Quality Collaborative. Her current quality improvement initiatives include improving pediatric sepsis recognition and management, croup care, and implementation of clinical care guidelines and order sets. Joining her this evening, Dr. Jacqueline Corboy. She's a pediatric emergency medicine attending, as well as the Director of Quality Improvement for Lurie Children's Division of Emergency Medicine. She completed her residency in pediatrics at Columbia Presbyterian in New York, her fellowship in pediatric emergency medicine at Harvard's Boston Children's Hospital, and has a master's degree in healthcare quality and patient safety from Northwestern University. Currently, she is an assistant professor of pediatrics at Northwestern's Feinberg School of Medicine. While much of her time is devoted to practicing clinical medicine in both the academic and community setting, her focus is on the development of clinical guidelines to promote evidence-based medicine and involvement in local and national quality initiatives that focus on sepsis, antibiotic stewardship, resuscitation, asthma, and mental and adolescent health at Lurie Children's. In addition to her role as the Director of Quality within the Division of Emergency Medicine at Lurie Children's Hospital, she is heavily invested in the education and mentorship of medical students and trainees in quality improvement methodology. They join us tonight for their presentation, This Patient's Gotta Go, Lessons from QI That Can Save Lives. And they will be covering the following objectives: identifying the role, best practice alerts play in improving emergent patient care and pediatric readiness. Discuss areas where communication breakdown can take place between facilities and steps to prevent miscommunication. And lastly, reviewing models for post-transfer case review and quality improvement. So please join us in welcoming Dr. Koopman and Dr. Corboy.
Thanks so much, Kelly. I am going to share our screen, but I have to give a huge shout out for that amazing presentation on quality methodology that we just heard. And that's going to serve as a great jumping off platform for our talk today. Yeah, so Joy, I think you might be unmuted too, but I'm going to kick us off. We have no disclosures from either of us. And again, you just heard what our objectives are for this complete talk that we have today. And I think we're going to just add a different perspective to other ways for utilization of quality initiatives in the clinical management of patients, you know, in addition to those process improvement methods that we just heard about. So Joy's going to kick us off with the case.
Yeah, so you have a 16-year-old female who presents with fevers to a Tmax of 101.7 over the last 3 days. She's been more fatigued and tired today, so they decided to come in. Although she hasn't had cough or congestion, vomiting, or diarrhea, she did have some pain in her right hip about a week ago that she attributed to running cross country, and that really got better after ibuprofen and Tylenol that she was taking for the first 4 days. And overall, she feels like that pain has improved, and she's able to walk, but now she has these fevers. She's healthy, doesn't have any drug allergies, and besides her ibuprofen and Tylenol, she's not taking any other medications. In triage, her heart rate's noted to be 116 with a blood pressure of 88/54, making her MAP 65. Her respiratory rate's a little fast at 28. She's afebrile with a temp of 36.5. And on her exam, she just looks a little tired, but she is responsive appropriately and has a little bit of tenderness to palpation there in the right groin, just when you palpate really deeply, but she will allow range of motion of that right hip, knee, ankle, and there's no visible swelling that you can appreciate. So in the first 30 minutes of her time in your emergency department, so the transferring emergency department, you have an IV placed and labs are sent. You order a normal saline bolus. So a liter is ordered based on her weight of 68 kilos. The pump is set to run at 999 mLs an hour because that's as fast as the pump can go. About 60 minutes later, her labs come back and you note her white cell count to be elevated at 18.6 with a left shift. She has slightly elevated platelets. Her CRP and ESR are also both elevated. While her chest x-ray is normal, you decide to do an ultrasound of that hip based on her inflammatory markers and this reported pain that she'd had a few days ago. You do note at that time her heart rate is still in the 110s. Her blood pressure is now 90/48 with a MAP of 62. And so a second normal saline bolus is ordered. And again, that's run at 999 mLs an hour. About 90 minutes later, you notice that her heart rate is still in the 120s. Her MAP is now 61, and a third normal saline bolus is ordered to be given on a pressure bag. The ultrasound of her hip has come back and it shows that she does have an effusion there. So you talk to orthopedic surgery over the phone and they would like her transferred to a tertiary care center where the hip can be aspirated. And they want you to hold off on antibiotics until that aspiration can be complete because they're concerned they won't be able to identify the bug if the antibiotics are given prior to the aspiration being done. You discuss with them your concern that she needs to have the antibiotics given and they would prefer transfer. So you talk to the transfer center at the tertiary care facility and they recommend antibiotics be given prior to transfer. And so you talk again with your orthopedic surgery colleague that's local and they discuss with interventional radiology who together as a team come in and are willing to do a joint aspiration prior to transfer. You've ordered the ceftriaxone to the bedside, but you're holding it at the request of the orthopedic surgeon. About 40 minutes later, the orthopedic surgeon has arrived, IR has arrived, they aspirate that hip, and you're standing at the bedside as soon as the fluid is out to push that antibiotic. At that time, the heart rate is noted to be 105 with a MAP of 76, so a little bit better than she'd been before that pressure bolus. But you're worried that now that the antibiotic's in, she's potentially going to decompensate, so you order an epi drip to be held at the bedside, and you're monitoring her blood pressure closely. 10 minutes later, her heart rate is noted to be 116, so it's going up again. Her MAP is now 62, so dropping. She's nearly febrile with the temp of 37.9. And so you ask that the epi drip be started with a goal MAP of 65 in this patient. As the nurse is going to get the pump for the epi drip, the transport team arrives at the bedside. They load up the patient and say, hey, we'll just get that epi drip started en route, and then they leave. 10 minutes later, while the patient is in the ambulance on the road being transported to the receiving hospital, her heart rate goes up to 120, her MAP drops to 59. And so the transport, the team in the ambulance calls their receiving facility who recommends a rapid push bolus of 1 liter of normal saline. 30 minutes later, they arrive at the tertiary care facility, so the receiving facility, and still her heart rate is in the 120s with the MAP now of 63. So an additional liter of normal saline is given, over 20 minutes push-pull, and orthopedic surgery is consulted. So that's your time 0 at your receiving facility. 30 minutes after that, so 300 minutes after she had initially presented overall, her heart rate is now in the 110s again. Her MAP is 69. An additional 1 liter normal saline bolus is ordered to be given over 20 minutes, and ortho recommends a musculoskeletal MRI prior to her being admitted. 50 minutes later, she returns from MRI. Her heart rate is still in the 110s. Her MAP is now 64, and the epi drip is started. An MR shows that a right hip osteo with an adjacent hip inflammation and interarticular effusion. And so they decide they're going to take her to the operating room. She goes to the OR, undergoes hip washout successfully, but they're unable to extubate her following the surgery. And so she's transferred to the PICU, intubated after that OR visit. Over the next several months, overnight, she develops acute complications of severe sepsis and septic shock with pulmonary edema, kidney failure, and multi-system organ failure. She spends months getting her antibiotics, recovering in the ICU, and then going to rehab facility and slowly recovers and gets back to baseline. So what went wrong? I'm sure you're all sitting there thinking, well, let me just tell you, a million things went wrong. And yeah, a lot of things went wrong. So how can we improve these outcomes? How can we use BPAs and QI tools to help these kids get better care? How can we put in place clinical care guidelines that might help things move more promptly and more smoothly? And what can we do to communicate better so some of these errors don't occur? You all probably know about sepsis, so we're not going to talk about the mechanics of that, but kids are not small adults. Early stages of sepsis can be subtle and they're really difficult to recognize. And hypotension, unlike in adults, is usually a very late finding and often can lead to irreversible end organ damage. So time matters. We need to promptly recognize their temperature, their heart rate, their blood pressure, their mental status, their perfusion. And if you can see these things and these early signs of sepsis, that can help you identify sepsis earlier. Every hour that you delay in recognizing a patient that's in SIRS or sepsis can lead to an increased risk of mortality by 8%. And studies suggest that automated BPA screens can really actually help aid in early identification.
So I'm going to take it and talk about what are these best practice alerts or advisories, and how can quality improvement help you by means of developing some clinical care guidelines at your institution for some of these high risk and high morbidity and mortality processes that you might be seeing, even if they're infrequent. So there's been a lot of data showing that particularly in high risk conditions like sepsis, having an electronic best practice alert or advisory in addition to, clinical judgment can really help in aiding recognition of this particular disease process. Just because, some of the symptoms are so commonly seen, you don't know whether it's the cold or a flu or if the child really is developing sepsis. So, initial data showed that if you just use electronic alerts alone, and these are based on vital signs, they're really not very sensitive in helping you determine what you're looking at, whether it's sepsis or something more benign. But they were pretty specific, particularly because they're aimed at identifying abnormal vital signs. But when you combine these with clinician judgment, you increase that sensitivity of identifying sepsis to the point where you can have some early interventions to almost 100%. And this is what it looks like in real life. We just learned a lot about quality improvement, but one of the ways we display improvement in quality are through run charts or statistical process control charts, because you're looking at a process over time. So this is looking at CHOPS, emergency department, and their proportion of missed sepsis prior to implementation of an electronic sepsis alert and their clinician identification education. And you could see that they were missing about almost 20% of sepsis cases prior to implementing this best practice advisory. And then after that, it decreased to 4%. So real effective identification that allows early management and hopefully helps decrease that morbidity and mortality that we see with delays in treatment. And just what does it mean to use these best practice alerts? So this is a conceptual map of what it does. So you can see initially you start with it looking at all patients. And then what it does is it triggers you for the abnormal patients. So here you see that patients with normal heart rate and blood pressure get removed from this screening. So it only leaves patients with abnormal blood pressure or heart rate. And here we're really looking for tachycardia or hypotension. So the first alert that a nurse gets after putting in the vital signs is just going to alert them to patients with these abnormalities. And then a second alert is going to come up where really the clinical acumen comes in. So they're going to have to decide, does that patient have a fever? Are there signs or symptoms of infection, right? So any patients that don't have fevers or a recent history of fever or a sign or symptom of infection, they come out of this. And so the alert stops firing and the triage process goes on. But if those patients do have either a fever or signs or symptoms of infection, then a tool comes up asking, are they part of a high risk condition? Do they have abnormalities on their physical exam? And that prompts patients to screen positive for a concern for sepsis and really kickstarts that initial treatment process. And Joy's going to take us into what it looked like implementing this in our community hospital.
Yeah, so we had a BPA in the system, and we said, what is working well with this? What is not working well with this? Because it was really frustrating to everybody. And like we had said, it's hard to identify, is this tachycardia just because they have a viral illness and they're febrile at the time, or is this really something else? So we had 100 patients that would met criteria for the BPA to fire. The BPA itself fired over 1,000 times. So more than 10 times per each patient that had vitals that were consistent with possible sepsis. The nurses then, if you can imagine in your everyday going about your nursing care, you're being interrupted 10 times in the midst of doing the things that you're trying to do within the chart to get the patient care given. They then had some response, but not a completed screen 466 times. So almost 5 times per patient that the BPA had vitals that would suggest that the BPA should go off. And in the end, only 54% of people were being screened and 46% didn't even have the screen completed at the end of the day. So we went back and said, why is this happening? And a few of the things we noticed. One, if a child got Tylenol or Motrin, ibuprofen or acetaminophen before they got to the hospital and their fever was gone, the system didn't realize that the child had a fever and that the fever had just been treated. And so that tachycardia or hypotension might not even be identified as a source because there was no way for the computer to be smart enough to know that they had a fever. So we added a little box in the triage vitals where it's like reported fever at home in the last 24 hours. The nurse just clicks there, right, when she's filling out all the other vitals. We also have these 3 clinician assessment questions that can be answered quite quickly by the nurse doing the triage. So they assess their mental status, they assess their CAB refill, and then we added this high risk condition. So kids who have like sickle cell anemia, or children who are under 2 months old, or kids who are at more risk for having severe, serious illness, those boxes can really easily be clicked by the triage nurse. And then finally, what we realized is there's a little X in the top corner where you could just click out the X if you didn't want to fill out the screen at that time, which is not helpful when we're trying to rapidly identify sepsis patients, right? And they also have the ability to hit defer. And so we are finding that the defer button and the X out in the top were being hit a lot on these patients, and that's why these screens were being done. So we made it so you have to select if the patient, your only way to clear out the screen is either to complete the screen or to state that they have an ESI-1 active resuscitation in place, that they have a trauma or a fracture, which could be accounting for their hypertension, or that you're assessing the chart for quality review. If you don't have one of those reasons, then you have to fill out the screen to be able to move forward with your work. And over time, what we found is that nurses are like, yeah, this is really easy because it's like second nature to them now that this is what you do, all these things, and they can easily complete it. Once that initial screening BPA goes off, then there's a huddle BPA, which the nurse then finds a physician and they decide if the patient falls on the sepsis red pathway, sepsis yellow pathway, or if the physician has assessed the patient and says, I don't think that this patient is septic. We did note that when the child is being triaged, it takes probably about 10 minutes in reality to get them from our T1 triage to a room and a nurse and all the things. So in the huddle BPA, they do have the ability, they can't X out, but they can say, remind me in 10 minutes so that they have time to get the patient from the triage room to their active room for care and notify the physician. Once they've hit remind me in 10 minutes, that's not an option again going forward. So you can't just say, remind me in 10 minutes, remind me in 10 minutes, remind me in 10 minutes. And so when we looked at the numbers following these interventions and our reassessment of how things went, you look at the next slide.
Yep.
We were able to decrease the number of interruptions these nurses are getting to 150 for the 100 patients. It was went off 151 times, so significantly down from over 1,000. So it's only going off about 1.5 times per patient. The BPA only had other acknowledgments about 1.2 times per patient. We increased the rate of patients who had the actual sepsis screen completed to 85%, and we decreased those kids who were not just having a screen completed at all to 14%. And this is within like the first month of intervention and the change being made. So by looking back over what wasn't working, we've really been able to make it so it's no longer, you know, the boy who cried wolf, where the sepsis BPA is going on off on every kid and there's alarm fatigue, to like, hey, this is going off. I've done the right things, and now we're identifying these things and moving on with the care the patient needs. So when we talk about, we're going to shift gears a little bit now and talk about, so that's how a BPA can help us like realize a patient has sepsis. So now we think, hey, this child is at risk of sepsis. Now what do we do? How can we improve that care? Well, in pediatric sepsis, you probably heard it, we talk about this golden hour. During that time, we're supporting their ABCs. We're trying to get antibiotics in quickly, the blood culture sent, fluid resuscitation, where we give them a bolus quickly, we reassess, we repeat up to 3 times as needed, but then quickly and rapidly initiate vasopressors if they're in fluid refractory shock. So guidelines suggest that this is the care that these patients need, and if we can give them a bundled approach, we can really improve their benefits going forward and in their treatment.
And this is really where clinical care guidelines come in. And if your facility doesn't have clinical care guidelines that are specific for pediatrics, you might just want to take a look at the types of patients that you're transferring and see if you could identify patterns for the higher risk conditions that you're seeing. And it might be worthwhile investing time and effort in developing some clinical care guidelines. Almost every hospital should have a sepsis guideline. Most of the time, it is specific for adults. So if your hospital does not have one that's specific for children, you could look at the Society for Critical Care Medicine's Surviving Sepsis campaign guideline that came out in 2021. It's really easy to follow, and you could really just print this out and have it ready and do an education with your providers so that they're able to follow these guidelines. It again recommends, early fluid resuscitation with a maximum of 60 mLs per kilo. So that's a maximum of 3 boluses, and then early vasopressor resuscitation so that you're not fluid overloading all these patients. It also differentiates between patients who are in septic shock and then patients just in whom your suspicion for sepsis is high, but they're hemodynamically stable. So for those patients that are hemodynamically stable, it's recommended that you give antibiotics within 3 hours. But for those in septic shock, that golden hour really is very important, and you should be getting those antibiotics in within 60 minutes. This is also something that quality improvement metrics and measures surrounding the treatment of your patients who present with sepsis are critically important, because time really does matter. And you want to make sure that you're getting those timely treatments to the patient, even prior. These are things that even the most minimally resourced transferring facility can provide to patients before they're transferred for, definitive management. Everybody has IV fluids, although, currently that's a problem just because of our source issues. But you also can provide those antibiotics in a timely fashion.
So at Lurie, we have, we're very privileged to have several clinical care guidelines. We do have our own specific sepsis one, which is based off of the slides that Jackie did. We also have a clinical care guideline for musculoskeletal infection. And we have them for a lot of things, but we just bring this one up it's because it is pertinent to our case. So these clinical care guidelines have step-by-step recommendations for the different conditions that the patient is presenting with. In this case, it's for bone and joint infection. It recommends laboratory testing and imaging. It recommends when consultation is needed, treatment recommendations, and the best evidence on those. But remember, not all of these can or necessarily should be performed at the transferring hospital if the patient is going to be required to go to the receiving hospital either. And so these are very site specific. So when I work downtown at Lurie in our Chicago location, it's different than some of the care that I'm able to provide when I'm out at one of our outreach centers. Also, these clinical care guidelines at Lurie are interconnected. So you'll see here in our patient, we had a high suspicion for infection, and it links us directly to the sepsis CCG. So it kind of takes us off there like, yeah, you may need to deal with this bone and joint infection, but right now your kid seems, you're worried about sepsis, that's more important. And then it has like a direct link. So things to think about if you're putting together clinical care guidelines at your location. And then like we had talked about earlier, sometimes all the steps don't need to be done at your facility, even if there's pieces of it that you can do, if it's ultimately going to delay the care that they're getting or the ultimate care that they need. So in our child's case, they had the elevated white cell count, ESR, CRP. They were at high risk for musculoskeletal infection. We were concerned, yes, could there be a joint effusion? Yes. There was not something I could aspirate actively in the emergency department. So is it worth the delay and the time to get IR and other people involved, or do you give the antibiotics and just transfer? So those are things to keep in mind, because not every clinical care guideline, like you can't just pick up one from one location and bring it to yourself. You really have to see what kind of things you have available at your location and make them work within your own system. So where can communication break down? Well, just about everywhere. What did the transferring hospital say? What did the receiving hospital hear? Who's involved in those conversations? And what information was conveyed by to the new treatment team who's receiving the patient, and who's giving that information? So if you look at our case, here's a perfect example. This child, clearly one of the main communication breakdowns was fluid resuscitation. So a patient's estimated blood volume for our patient, being a 64 kilo female, was 4,480 mLs. This child received over 350 minutes, 6,000 mL. So more than her entire blood volume of normal saline. So this, this is one of those things that communication, how could we have improved that communication? Well, the transferring facility realized that the patient got 3 liters and had requested that the epi drip be started. The transport team who was physically there picking up the child heard that the epi needed to be given, but 10 minutes later, when the patient's blood pressure dropped, called medical control, who was not the dispatch person who took the report and knew that the child had already received 3 liters, but instead the physician who is going to be taking over the care of the patient, who essentially said, this kid looks septic, we're going to do the rapid boluses for to see if it's fluid responsive shock. And so additional fluids were ordered on top of that. So direct communication can sometimes help with some of those errors. And sometimes people get the information, but depending on who's hearing it, they may not realize the importance of the information they're hearing.
Okay, so that brings us to transfer communication. So many hospitals who are transferring patients go through a transfer center, and that transfer center is established to coordinate the care of that patient between the originating facility and the receiving tertiary care facility. Oftentimes, sending physicians do not have the ability to communicate directly to the accepting attending, which was one of the issues in this particular transfer case that we have presented to you. And then the other issue is sometimes once the transport team arrives, you're communicating directly to that transport team, but then when they leave your facility, their new medical control is the receiving facility. So it's like a game of bad telephone, and you don't know who received what information and where they are in that process of understanding the totality of the care that patient received at the originating hospital. So as a sending hospital, you should always have the ability to request direct communication with an accepting physician. Most of the time, if you're dealing with a transfer center, you might have to specify that request. I know some transfer centers automatically will link you in with the receiving physician, so you can do that direct communication to the receiving party. But if that's not the case, I know some transport centers have algorithms and they're able to function independently of the receiving physician. you could request that, particularly when you have a high-risk patient and you want to make sure that all your care has been explained so that they know where they're picking up. Also, it's really important if your initial care differs from what the consultant or the receiving facility is recommending, it's better to kind of communicate that directly with those people. Either, you might not have the ability to do some of the things that they're asking. So it's very important that the receiving facility knows that, the patient is going to come to them without having had, maybe an important imaging study or things that might be requested. It's really important, if you're transferring a patient that needs consultant care, to also communicate directly with that consultant or have the transfer center contact that consultant so that they know that they're going to be needed when that patient arrives at the tertiary care facility. And then be very explicit about what your concerns are about that patient, because oftentimes the receiving facility might not know where your head was at, particularly if, all of your paperwork might not be complete, or the paperwork might have gone to a different provider. There's often residents and multiple layers of people taking care of patients at tertiary care facilities. So it helps a lot to do that directed communication. What about quality reviews and quality improvement? Well, you've been hearing in the past 2 hours all about how quality improvement initiatives are incredibly important in both improving the care at the transferring facility and also at the receiving facility. So if you're the transferring hospital, what are the things that you should be reviewing? We just heard a lot about, a lot of process metrics that you should be reviewing, but you should also be reviewing the care that the patient is receiving. What should the receiving hospital review? And what should the transport teams or the ALS teams that are taking your patients to these tertiary care facilities review? And what do you do with that information? So if you're a transferring hospital, typically you're a community-based hospital, but you might not be. Sometimes tertiary care hospitals don't have specific modalities that a patient might need. Like you might need a vascular surgeon and you might not have one for pediatrics, even though you're a tertiary care facility. So you might need to transfer those patients. So it's very important to set up mechanisms to track all those transfers out of your facility. And we just learned about a tool that your hospital can use to track all of your transports. What's really, really important, though, when you're talking about the clinical care of those patients, is that you review these cases monthly with your interdisciplinary team. So that includes nursing, quality providers, if you have them, APRNs, PAs, if available, and providers and leadership. Because it's really important that you not just gloss over and make sure that boxes are checked, like the EMTALA form and, all of those quality assurance things, but you really want to know, what is this clinical care that you're providing? It's also really important to learn from the receiving facility what the ultimate diagnosis was. And we saw how there are sheets now that you can get to talk to your receiving facilities to find out what that ultimate diagnosis was. If it's different from what your leading diagnosis was, why? Why was it different? Were there things that could have been done differently? Could a clinical care guideline have helped you reach that, diagnosis, or at least have that on your differential, right? And a lot of patients that are transferred to outside facilities are immediately discharged from the ED. Why? Is there something that you could learn from this? Is there something that is within your hospital scope that you could start providing to those patients to keep them in their local emergency departments and near families? Look for patterns. Look at your time to antibiotics or fluids in patients with sepsis Are there delays? If there are delays, what are the things that are causing those delays and how could you change them? Look at vital sign abnormalities. Are you recognizing them? Are you discharging patients that have had abnormal vital signs without understanding what the cause are? These are things that can really direct quality improvement initiatives and, you know, help you educate your team in how to provide better evidence-based care for these patients. And as it was mentioned before, you know, meetings with the department and sharing that information is vitally important so that all can teach and all can learn from what's happening at your transfers. Sorry for my dog, she might be in the screen. And then what about our tertiary care partners, the receiving hospitals? If you're a part of a receiving hospital, it is really, really important to communicate back to the hospitals that are sending you patients, either by a letter or a phone call. And, you know, you most likely have more resources than those transferring hospitals. So it's really important that you assist in education, if education is needed, in providing guidelines, if the sending hospital is interested in that, and that you also have a mechanism in place to review those transfers into your facility to look for patterns from particular hospitals and then figure out how best can you assist them on their journey to providing evidence-based care and quality improvement initiatives. And then if you're part of a transport team, how do you track your cases and how do you review your care? And which of the cases that you transport are high stakes diagnoses that would benefit from having algorithms to make sure that these patients are also being treated with evidence-based therapies while they're in your care, right? And it's important to work with frequent referring centers to learn more about their specific site needs. And also, you can also assist in educating lesser resourced facilities.
All right, so let's go back and rewind and see how, if we would implement some of these clinical care guidelines and best practice alerts, our patient's care may have differed. So the same kid, so we're not gonna go through the whole history again. But now at 30 minutes, the BPA tells you, based on her arrival vital signs, that she's at risk for sepsis. You immediately recognize this based on the BPA and think, yeah, that could be it. You place an IV, give your normal saline bolus, but you have a CCG in place that tells you, hey, this needs to be a push-pull bolus given quickly. So instead of just putting it on a pump that runs over an hour and rechecking later, you put it on a pressure bag to give over, you know, the 15 to 20 minutes. You order antibiotics initially because you're worried maybe this is actually shock. 15 minutes later, once that pressure bag bolus is done, her heart rate's still in the 110s, her MAP is 69, so kind of borderline still, and you reassess her. There's still no signs of fluid overload on exam, so you go back to your clinical care guideline and say, you know, maybe she could benefit from another normal saline bolus, but I'm going to also order an epi drip to the bedside. So she gets her second normal saline bolus, again by pressure bag, and when you recheck her blood pressure, you continue to recheck the blood pressure every 15 minutes to kind of make sure it's not drifting while you're waiting for that epi drip to get to the bedside. You send the labs and get a chest x-ray, which shows no heart, like cardiomegaly, no sign of infection. You get the ultrasound ordered of the hip, and her ceftriaxone is given because you realize that this child seems to have signs and symptoms of shock. At the 75-minute mark, you now have your labs back just like you would have we did earlier, and you notice that the white cell count is high with a left shift and an elevated platelet count in CRP and ESR. You've already ordered the ultrasound of the hip, and you're able to call ortho on call, and they want the patient transferred to a tertiary care center. At this point, you've already given antibiotics because you were worried about septic shock, and that's what you were treating. So that piece of the discussion is no longer on the table. Her heart rate is now in the 110s, her MAP is 62, and she's almost febrile again. So her epi drip is initiated, and maintenance IV fluids are started with repeat blood pressures continue to be checked every 15 minutes. The tertiary care center is contacted and they will come get the patient. It still takes them, 45 minutes to get there to you. They arrive, the patient's already on the epi drip for the hypotension that they had. Her heart rate has now improved to 96 with a MAP of 79. Her temperature is coming down a little bit. And then she makes her 40-minute trip down to the transfer facility. And when she arrives there, her heart rate's 92, her MAP is 83, with a much improved blood pressure on that epi drip. She's alert with no signs of fluid overload. She's seen by ortho, who again still is ordering the MRI, which finds that right hip osteo with the adjacent interarticular inflammation and fusion. They take her to the OR. And she is able to be extubated following the procedure in the OR, taken to the PICU just to wean those pressures and continue her IV antibiotics. And she does well, and she recovers quite quickly and is able to go home much sooner. So that's our case for you. Hopefully you can learn or saw from our case how having these little things like BPAs and clinical care guidelines in place, and then reviewing and doing quality initiatives to try to improve the care of these patients can help things run more smoothly for you.
And I'm just looking at the chat, and we got a question: will the guidelines be available after the session is finished? And we're happy to send through EMSC those guidelines so that they can get out to you. Remember that they are site specific, so you'll definitely have to tailor those to your own institution. But there are several of Lurie Children's clinical care guidelines that are available on our external website. So if you just, go Google Lurie Children's clinical care guidelines, they'll come up for you. I believe sepsis is one of those that's on there. I'm not quite sure if musculoskeletal infection is on there, but also a plug for Children's Hospital of Philadelphia. All of CHOP's clinical care guidelines are available externally for anybody who wants them. And they're also, you'd also be able to implement those in your institution with modifications where needed.
Right. We do have one question that was put in the Q&A, and it's related to your case scenario. And the question is,
we lost you.
We lost you. I do
why
see the
were you
question.
anticipating a decrease in the
Yeah, so oftentimes when you give antibiotics, they will have this kind of usually like about a half an hour later, I don't know, Jackie, you can comment too, but usually like about a half an hour later, you can see this drop in their blood pressure. And it's, something that's not all that uncommon in these really sick kids. And so I think that there's sometimes things that the longer you do things, the more you kind of see these patterns. And like Jackie was saying too, with when you have a variety of trainees, sometimes they haven't seen those patterns over time and are not anticipating kind of what the next step will be. So yeah, with the initial case, we were worried that the blood pressure would drop once the ceftriaxone was given. And especially with this child who we give them fluid and the blood pressure comes up and then goes down and up and down. It's like they're not really being fluid responsive. We're seeing the fluid and then it's dropping again. It's not going up and just staying up. So yeah.
Yeah, and when a patient is truly septic, and there's bacteremia, right? So that's what you're worried about, that there's bacteria floating through the circulatory system, and you deliver an antibiotic, and that antibiotic starts to work. You start this entire cascade of inflammatory markers that cause vasodilation and third spacing of fluid. So you oftentimes get a severe episode of hypotension about 20.
Oh, we just lost you, Jackie.
Is their physiology.
Thank you. Any other questions? Please feel free to raise your hand or put them in the Q&A. And just one more request before we move on then to our next presenters. As you've logged in, if you do not have your first and last name identified, Please make sure that you change your name so that we can ensure that you get the appropriate credit for your attendance tonight. Check your chat boxes. I know that the team has been working hard to reach out to everybody that's not identified with the first and last name. All right, let me share. We'll move on here to our next. Yes. Right. And our last presenters this evening, we are joined by Shannon Flint and Kimberly Lipetzky. Shannon is a clinical educator, pediatric specialist, and mentor. She has over 2 decades of pediatric nursing experience and is highly committed to quality pediatric care, as well as improving pediatric outcomes. Through the implementation of pediatric nursing education initiatives and the development of pediatric quality metrics, Shannon strives for the highest standards of clinical excellence and a culture of continuous improvement in pediatric healthcare. Shannon resides in Crystal Lake, Illinois with her husband, 3 children, and a black lab named Astro. Kim Lipetzky is a results and data-driven quality coordinator of pediatrics and trauma services at Rush Copley Medical Center, which is an EDAP-designated Level 2 trauma center in Aurora, Illinois. Kimberly is passionate about tracking and measuring performance to enact real-time change and overcome any obstacles in excellent care. Kimberly was honored to be awarded the Daisy Award her first year as a bedside RN and to be featured in the Chicago Sun-Times regarding pandemic nursing at trauma centers. Kimberly resides in Naperville, Illinois with her husband, her preschool-age daughter, and their French bulldog. So we welcome them this evening for their presentation on Regional Pediatric Quality Improvement in Action. And they're focused on covering the following objectives: explore fundamental principles of quality improvement process, describe one region's approach to quality improvement, evaluate an example of pediatric QI in action, and outline some valuable tips and tricks for the pediatric quality coordinator, which is the term utilized here in Illinois for the PEC role, that pediatric emergency care coordinator. So we'll turn it over to you ladies.
Hello. Hi, everyone. First, want to say thank you to Dr. Corboy and Dr. Koopmans for such a great presentation on the use of clinical care guidelines and pediatric transfers and tips for how to improve that in our roles as pediatric quality coordinators or in the PEC role. My name is Shannon.
I'm Kim, and we are going to talk to you guys today again about regional pediatric quality improvement in action. So we really want to provide kind of a boots on the ground, real world scenario of a QI process from start to finish. So our region's approach from methodology, philosophy, and then an actual example of a QI project that we just finished most recently. So we can kind of show you exactly what this really looks like and the nuts and bolts that are really involved in a QI process in our region. What gets measured gets improved. Peter Drucker. We love this quote because we feel like it really embodies the spirit of QI and our philosophy towards QI, which is really you don't know what you don't know. And I'll get into that in a second, but just the act of actually measuring something is just so useful in terms of focusing your efforts and understanding where you stand and where your work should be headed. QI can seem like a really daunting, multi-phased, laborious process, but by just thinking of it as truly a measurement and reacting to that measurement, you can kind of break it down to more tolerable and digestible parts. So the fundamental principles, I'll kind of go through this quickly because Krystle did such an excellent job of detailing QI and what exactly it means, but we thought it would be useful to get a foundation of our interpretation of QI before we give our examples. So QI, the definition that we choose to focus on is systematic and continuous actions that lead to a measurable improvement in the healthcare services and the health status of a targeted group. And the term that we really like here is truly measurable. So why perform QI? So again, you don't know what you don't know. You may think that your hospital or your medical group is performing a certain way within a field of patients that you serve, for example, but you don't really know unless you actually kind of get into that process of auditing and measuring that performance. And in that process, you elucidate weaknesses, gaps, and even strengths. And by identifying where you fall in performing in certain metrics across the field, across the board, you can focus your efforts to make the greatest impact. So by targeting the needs that are most specific to how your hospital or your group is performing and where you need the most strength and where you need the most to grow. So we try to focus on measurable outcome analysis and the intervention being a success or a failure. So by intervention, we usually focus on education with our emergency department RNs, and we'll talk in a little bit about what that looks like. But your intervention may not be as successful as past interventions, but it's through this kind of continual process of quality improvement and analysis that you start to get better and you improve over time about which interventions are more successful than others and actually impacting change. It's all a process and the work is never truly done. So how do we do this and how is this done? So we always say, don't be afraid to start small. The project can grow. It really can start as a simple question. You can seek to get an answer to such as like, how often are we doing XYZ in our emergency department? What trends are we seeing? How often are we doing this or not doing that? And those simple questions can be the framework, the simple outline of the scaffolding that you then build your entire QI project around. So best practices or regional goals can also be a guide for you to come up with QI topics. You don't have to reinvent the wheel. As PQCs, we are always tracking certain metrics anyway, and you can feel free to use that data for the creation then of your QI project where you kind of get a little bit more in depth into that field that you may want to improve upon. We use the model for improvement as a framework, and I will kind of briefly talk about this because, again, Krystle did actually speak specifically to this, but we call it the PDSA cycle, the Plan, Do, Study, Act, and it's the 3 fundamental questions, which, again, Krystle did detail. But we like this model because it truly is a circular approach and that the work is never really done. And you're always going to be continuously focusing on the improvement and the acting stage as you go, even after the QI project wraps.
So let's build on that framework that we've just reviewed to guide us in our QI efforts. And the goal is always continuous improvement in our pediatric outcomes. To start with introductions, so Region 9 consists of 14 hospitals across Northern Illinois and the Chicago metropolitan area. Our hospitals range in size from small community hospitals to large academic research facilities, with resources that range from limited to abundant. But despite these differences, we all share a common goal: the best outcomes possible for children in the emergency department setting. So tonight we're going to focus on a specific project our region undertook related to pediatric pain management. So we're going to begin by discussing how we approach quality improvement, and our process really starts with data. We track trends as PQCs and identify any gaps in performance, which helps us pinpoint which areas of improvement we want to focus on. Once we've uncovered that area, the PQCs get together, we discuss it, and then we vote on it. From there, we develop a plan, set a timeline, always making sure to check in regularly and adjust the plan as needed. It's important to note that sometimes that specific intervention or purpose isn't always clear from the start. So sometimes that initial data that we find helps guide our course of action. A quick overview of our process: it's pretty simple. Data is submitted to a point person who then cleans and compiles it. Typically, we use Excel. And then we create visuals such as charts or graphs, and that point person brings it back to the group. And the graphical data is used to help it make it easier to identify trends. So for our QI project kickoff that we're going to talk about, we're going to apply the PDSA framework to our region's pediatric pain project. And this is one area that across all of our sites we are seeing as a problem and something that we wanted to improve on. So the first step in the cycle is plan, and we begin by defining the problem and developing a clear strategy. So some of the questions we came up with as we were discussing as a group included: were we assessing pain? Were we using the appropriate pain scale for age or development level? Were we providing a pain intervention, whether that was pharmacologic or non-pharmacologic? Did we then reassess that pain? And did we assess pain at discharge? So with those questions in mind, we were able to develop an audit tool that was both effective while also being user-friendly for our PQCs. And we set a framework for them too. So that plan was for each PQC to audit 50 pediatric charts with exclusion criteria that included patients with a pain score of 0 or denied pain. Here you'll see, so what is represented on the screen now is a replica of the audit tool we created for the QI project. Pretty simple. We then established a realistic time frame. We didn't want to overburden our PQCs while keeping the project pretty manageable. So in February of 2022, we distributed the audit tool to all of our regional PQCs. By August of 2022, each PQC was expected to submit those 50 pediatric pain audits to the point person. And then that point person compiled the data and disseminated the results by November of 2022.
Okay, so we find ourselves in the due portion of our PDSA cycle. We adopt a 3-phase process of implementation. So we audit, which is usually a retrospective analysis of charts to analyze our performance. We base our intervention on those findings, and we implement said intervention, and then we perform a post-intervention audit to see if we move the dial, essentially. And if you're feeling daunted by this whole situation where it's multi-phase, don't be, because this takes months and the timeline can be fluid, and we're kind of always checking in with each other as PQCs to see if someone needs more time, et cetera. And I'll show exactly what this might look like in just a second here. So the pre-intervention audit, the first audit that we did, was a retrospective audit of 640 pediatric patient ED visits across our region, our 14 region EDAP hospitals. The data was compiled after it was turned into a point person, analyzed, and we kind of identified very early on that there was definitely room for improvement here. We were not adequately intervening in pediatric pain with patients that had a measurable pain rating or pain score of more than 1 on arrival to our emergency departments. And we were not adequately assessing and reassessing that pain after intervention. So we knew that there was room for improvement, essentially. And we also found through a literature review, actually, of national statistics that this was not unique to our region or our state, that nationally, actually, emergency rooms are undertreating or tend to statistically undertreat pediatric pain. So we were following in line with that trend. And then on the right hand here, you can see a graphical representation of our initial audit findings. You can see these are children that arrived with a measurable amount of pain to our emergency rooms, but we're only getting a pain intervention 50% of the time. If they did get an intervention for pain, they were only reassessed for the effectiveness of that intervention 35% of the time. And did they get a pain score reassessment at time of discharge or transfer? And that was only slightly more than half, 55% of the time. So from these findings, we set about to create a way to intervene and hopefully move the dial and improve these metrics. We decided a back to basics, essentially, approach to pediatric pain education would be best. We decided to use PowerPoint presentation as the tool to disseminate that information. And we were lucky to have 2 region PQCs in our group who created said PowerPoint. And we disseminated that information to all of our 14 hospitals a number of ways. At my hospital, I presented at our quarterly ER staff meeting. Some, however, used group huddles or breakout sessions. Some used online platforms like Net Learnings, et cetera, to disseminate that information. The education itself, the PowerPoint contained performance rates, current research, common misconceptions about pediatric pain, which was large, utilization of correct pain scales and what that looks like for that child, and then pharmacological and non-pharmacological intervention options. We did also include how each individual hospital stacked up against the entire region. So we are not afraid to create a healthy amount of competition amongst our regions on how, hey, this is how we're doing, and this is how our entire region's doing. We want to stack up. We want to be one of the best, right, in our region. And we found that that was a good motivator. So the beauty of the intervention that we chose is it wasn't just unique in that each hospital could disseminate the information however best fit their needs or their capabilities, but also the PowerPoint itself, the intervention itself was also modified to fit each facility. So we're 14 different hospitals. And as Shannon mentioned, we have a lot of different resources among us and we have different settings, et cetera. So the core information on the PowerPoint of the intervention about pediatric pain wouldn't be changed. But then when you got into the specifics, each pediatric quality coordinator could alter that PowerPoint to fit their specific ER's capabilities and standards. So for example, at my facility, we use Epic. So I was able to alter the PowerPoint to include screenshots from our Epic, our actual, where our nurses in triage are charting pediatric pain, where they're reassessing it and getting reminders to do so, et cetera. So that ability to modify and really tailor the intervention, we thought would help us to achieve a higher success rate. So how did we do with the intervention? Well, we achieved intervention saturation of over 400 emergency department nurses throughout our region. And based off the working with each other and constant communication on when that education was done being disseminated, we set a timeline for post-audit analysis.
So for our post-intervention timeline, this was in 2023, we used the same audit tool from our pre-intervention phase. And our goal remained the same, to complete 50 chart audits per PQC. The exclusion criteria also remained the same. We wanted to exclude patients with who denied pain or had a 0 pain score. When we were doing those. So PQCs were required to submit their audits by July of 2023. The point person then had until December of 2023 to compile the results, with dissemination of findings occurring in February of 2024. So we did give ourselves quite some time to be able to complete this. And this is something we also had to adjust over time. We're going to take just a quick step back to review what our target was for this project. So as a group, we came together and decided that we wanted 90% nursing compliance in the assessment, intervention, and reassessment of pain in our pediatric population. It's really important to understand what your goal is, because it allows us to compare our project results against our desired outcome as we move forward in this cycle. So we made it to the study set, and this is where we're going to analyze our results. It's important to highlight what went well, what was really successful, but also on the opposite, what was needed, what was an area of improvement, what didn't work as well. And so the key question we needed to answer here is, did we achieve our target? So to perform this analysis, we needed data once again. We really love our data as PQCs. We followed the same approach in the post-intervention phase as we did in the pre-intervention phase. We wanted to ensure that we were consistent in how we collected and reviewed all of the data.
So how'd we do with pediatric pain? Okay, so here are our results. And to break it down, we saw improvement across the board. We were super thrilled. We saw an 8% increase in compliance with receiving a pain score on triage, upon triage. We saw a 12% increase in use of the correct pain scale for that interaction. We saw the largest movement in terms of receiving or implementation of an intervention for pain, and that was a 27% increase. And then next largest, we saw a 24% increase in actual pain reassessment after intervention. The smallest change was about just a 5% increase in the pain score done at time of discharge and transfer. And in full transparency, this remains a difficult metric to move. But it's something that we keep on the forefront of our minds as we move forward as PQCs. After, no one wants to just look at numbers. I think it helps strengthen your argument if you create graphical and visual representations of your data. And so that's what we did here on the right-hand side, where you can see just one metric broken out visually: pain intervention received, yes or no. Prior to our intervention via education, it was 50-50, and then we were able to achieve 77% yes. Our children did receive an intervention for pain. And that included, of course, pharmacological and non-pharmacological, whatever was appropriate for that situation. So while we did not reach our 90% compliance in any of the specific parameters we measured, we made positive strides in every single parameter. So we considered it a success regardless. And it was clear that we were able to have a positive impact with that method of intervention. The goal needs to be sustainable, and the goal of improvement needs to be something that's kind of ongoing. So you're never really done, and it stays pediatric pain, and the treatment and the assessment of pediatric pain remains something that we continually work on. When you're doing QI, for example, with pain, we don't want to make sure that our kids in the year 2023 are treated adequately for pain, right? It needs to be something that's sustainable, that's long-term, that lives in the vernacular of our ER nurses and how they do their charting and their day-to-day assessments of their pediatric patients. So it has to be something that kind of stays on the burner regardless. And by sharing the results of our study of our QI project, we were able to get buy-in for some of our region hospitals. So some changes that we saw regionally as a result of publishing this data and sharing the data that we were able to achieve. Some hospitals in our region got better access to pediatric pain treatment in triage. Some hospitals achieved a better order set process or order process for pediatric pain interventions, or they were able to obtain better access to non-pharmacological pain measures for kids. So by showing graphical representations and visual representations of our work, you can pitch to administrators or people that might be requiring buy-in to help you move the needle on these metrics even further. So first, we always share the results of our study of our QI projects with our own PQCs. We share it among the region, and we hopefully celebrate our efforts. And then we also think it's really important to kind of have closed loop communication with our nurses. We don't want to just say to our ER nurses, hey, this is what we're doing poorly, do it better, and never talk about it again. We want to make sure that we share the positive results of their efforts. They need to feel that their work is improving and that it matters and that we're noticing. And that's been great. And then, of course, we shared this information with the state level EMSC. We also, I should mention, did present a poster presentation at the spring symposium for the ENA of Illinois.
So we made it to the final point in the PDSA cycle, but don't think we're done just yet. Remember, this is a cyclical process. So this is where we're going to decide our next steps. We ask ourselves, do we want to adopt, adapt, or abandon the changes that we've made? And do we need to initiate another cycle? So to evaluate our progress, we have to ask ourselves, how is pediatric pain being managed in our region now? So did the changes we implemented at each hospital improve pediatric pain management outcomes? And I think that as we heard from Kim and myself today, that we really did improve that. And so those are changes that were positive. Each of our hospital was able to demonstrate, and things that we adopted to keep and not change. But it's something in this cycle that now we're going to ask ourselves, when it comes to every QI cycle that we do as a region, is this something that we need to look at again? Is there something else with pediatric pain that we want to improve on even more? So our final insights on our project. So the PDSA framework is both easy to use and flexible. It provides a structured approach while encouraging a culture of continuous improvement. What all of us have talked about is setting clear goals. Each of our presenters tonight has really highlighted how important that is. And when we set clear goals that are measurable, it helps keep our PQCs really invested in the projects that we're doing and motivated to get them done. And then our last is engaging our stakeholders. It's really critical because it increases buy-in and creates the foundation for lasting change to improve our pediatric pain outcomes, or all pediatric outcomes.
Okay, so final little tips and tricks here. And we hope that you'll have questions for us too. Fear not, Excel is your friend. So I am a person who, if I opened Excel on my computer previous to this life I'm in now, I was Xing out immediately. I did not mean to do that. And I was not comfortable in Excel in any way. But now a year, 2 years into this role, I'm constantly moving my Word documents to Excel format because it's so useful and it's able to do so much. But you just have to get started. And there are tools and resources out there to help you. So there's just a little screenshot of some YouTube videos that you may find helpful. There's also Excel for Dummies book, whatever your learning platform is, but really just using it day to day and getting familiar with the different tools that are within Excel. It's really just essentially a calculator. You will be able to achieve what we have. I mean, everything that we showed you here today, the graphical representations and the data analysis, is not complicated. It may seem so, but I promise you, you're capable of it. It's not high-level stuff. You just have to not be afraid to get started, and you may make mistakes as you go, but you'll get better at it, I promise. There's people that work in Excel for 20 years, and they're still learning new things about it. So it's okay. We can manage the small piece and be proficient in it. Pick topics with a reasonable sample size. If only a small population in your region or your hospital is going to be affected by whatever you're trying to QI, it's going to be kind of frustrating and somewhat daunting to get enough data to study. And then also your efforts may not make the greatest impact because it is such a small area. But maybe that's something as a region that you decide is worthwhile because it's something maybe that's been identified as a huge issue, even if it is a small population. But we recommend choosing a reasonable sample size and something that's going to make a great impact for your entire population as a region. We want to highlight that it's okay. Your intervention may not be successful. So your method of providing or enacting change may not be the greatest. That's okay. It's all a learning process. And you'll change your intervention at the next QI cycle. It's no time is ever lost. It's always a learning opportunity. So for us with this pain project, we didn't achieve our 90% in any single parameter, but we still considered it a success. And we're going to tweak our interventions moving forward, maybe to be a little bit more face-to-face or whatever the situation that PQC thought might have made her hospitals or his hospitals outcomes a little bit better. You're kind of just always improving. And next time you may even enact more change. The work is never truly done. I think we kind of highlighted that. And sharing is caring. So in Epic and what my hospital uses, reports, order sets are shareable across your platforms. But I know Cerner, I believe, they have shareable platforms as well. We just heard from 2 doctors that have excellent platforms for treatment pathways. But even just to gather the data to QI, there's ways to do it that one hospital may already be doing, and you don't have to reinvent the wheel. So I recommend making friends with 1 or 2 people from your IT team at your hospital and talking among your region about what systems they use and sharing your QI tracker tools, et cetera, because we can really all help each other improve and be better. So with that, we hope that you'll have some questions for us about the QI process, the actual nuts and bolts of creation to implementation, or really anything at all.
And again, just as before, please feel free to raise your hand or put your question in the Q&A section so we can answer your questions. Yes, Dr. Corboy.
Hey, I put it in the chat too, but I was curious as to one other way that you might want to consider displaying your data would be plotting your data over time. I think if you could think about maybe like auditing 20 charts monthly on all of those things, and then you can plot the percentage of, yeses from, pre-implementation to post-implementation on a P chart. It'll allow you with a little more granularity to see whether your interventions have made any difference in your improvement, and you can use it to track different sites over time, as well as like your aggregate data that you're collecting, especially if you're going to publish this project. I think it would give people a lot of information on, what your interventions have led to and which things are successful. It just gives you a little bit different data than your aggregate data, like put in pie charts or bar graphs.
Yes, totally. I think we're kind of seeing that with the current QI project that we're working on now. By creating a timeline, you can also kind of suss out more what's correlation versus causation in your data. And we're finding that with the current asthma project that we're working on, certain factors that may affect our outcomes. And so I agree. I think it is useful to apply a timeline to your data audit. And it's something that I think we're going to try to do more of moving forward.
Great. Yeah. If you need any help, Shannon knows how to reach out to me.
Thanks, Jackie.
Yeah.
There is a question in the Q&A. Any specific ways that you encourage buy-in by your nursing staff with whichever metric you are trying to achieve?
I think this is something we struggle with, and as all of us meet quarterly as PQCs, this is something we all talk about. And so, we're trying to just continue to raise awareness through our staff meetings, PE huddles. We don't ever want to cast it in a negative light, because we really want to move it forward. So I think it's just small little bits all the time. So with a really positive attitude.
Yeah, you're really trying to plant a seed. And I find that with our nurses, when you kind of get into the why behind, this is why we want this performance metric. This is why this goal is the way it is, because here's what's even happening with the patient physiologically, or here are the risk factors or whatever. Then it does get a little deeper ingrained, and it can actually change practice because they understand why it's valuable. It's not just to check a box on, yes, I did this, I charted that. Here's what's happening with this patient and why this metric matters specifically, why we're focusing on it, et cetera. And national statistics too, like this is what we see is a problem nationally. We want to be better than that. We talked about a healthy amount of competition, et cetera. All of that, those are all tools that you can utilize in your favor to help move the metric. Nurses, we're constantly throwing more education at our ER nurses. They constantly have new metrics that they have to meet. And it's easy to get burned out. So I think explaining the why behind the reason of let's do this better, right? But then also making it something that they want to do better. I don't want to be on the naughty list for not charting this, or I don't want my hospital to be known for underperforming in pediatric pain or asthma or whatever the situation is, and kind of framing it as something that matters, not just because we want to check a box or we want this number to improve a certain percentage point.
Great. We've heard that you guys are working on a new regional project, but one of the questions asked in the Q&A was, are you still in Region 9 collecting pain data?
So currently we are not collecting pain data, but we did just start. So we're currently in a cycle for pediatric asthma, and we're currently voting on topics for our 2025 project, and pain was brought up. So that is something we're currently voting on to see if this is something we want to circle back to and start again.
But most of us do QI pain regularly in our individual hospitals as well, just not to the most thorough extent as we did actually during our QI project on pain, but we're always tracking pain. I know I'm quantifying our performance on our transfers for pain every month.
Yes.
Did we do it at time of discharge? Did we reassess after intervention, et cetera? So it does kind of live on regardless of it being the focus of your current QI project or not.
Okay, great. There was another question. They started off by thanking you for the great presentation. But the question was, did you have much staff turnover at the facilities? And if so, any lessons learned for getting new individuals or new staff members up to date?
So it's not something that we tracked, that we track in our region is what our nursing turnover is. But I think since 2020, most of us can agree that our ERs have seen a lot of turnover in our nursing staff. So while this pain project happened in 2022 and 2023, a lot of us partner with our other nursing leaders in our departments, such as our educators, and bring this as a topic to our onboarding process, at our staff meetings, or if we are fortunate enough to have skills days, so things like that. So that is definitely something we bring back to our teams to help implement. It's not something we as pediatric quality coordinators are always able to handle on top of our other duties, but it's something we bring back to the greater team.
Yeah, staff turnover is a huge challenge, and it will always be. But I think getting face to face with your new hires to kind of focus on what your pediatric goals are for your institution, what you're focusing on, and kind of what you expect is a great idea. And then also having point people. So having a champion on your unit. So this nurse is our pediatric pain champion, and maybe one each shift, night shift, day shift, or whatever it is. And then that person can, on a peer-to-peer level, help share the education about here's why we're doing it this way. Here's when you should be reassessing pain or using this pain scale for this type of patient or whatever, and empowering staff to kind of spread the word, because you're only one person and you're only there a finite amount of time. But that peer-to-peer education can't be undervalued. And then also just that face-to-face, of course, with the new staff is key as well.
We have another question, and this actually goes to each of our presenters. We hope that each of you will unmute and respond. But if you could each identify one barrier that hospital personnel give for not doing QI and how to address it.
I think for me, one barrier would be a lack of administrative support to have the time and resources to do that QI. So I think to combat that is to be the little voice, like to be incessant with it and just really push for it. And that's a lot of what we do as pediatric quality coordinators or in that PAC role, is just really bring those topics forward.
Yeah, sharing your results is huge too. Like we were able to get changes in some of our region hospitals by our nurses, our PQCs bringing the graphical representations of what we were able to do to administrators who had the power to affect change in terms of access to like measures that we might control pain with iPads or whatever, like distractions, whatever access they needed and order sets, etc. But I also think making sure that your nurses are passionate about it is key. And trying to keep that passion for the improvement is huge.
Yeah.
Yeah, I would like to second that. Lack of protected time is probably the number 1, 2, and 3 reason why it's difficult to engage all members of your team, but I can't highlight enough how important those wins and celebrations are, so that your team understands and the people that you're working with understand all the benefits that come from doing that work and become invested. I mean, not everybody's going to be passionate about everything. I mean, we did something on enemas, and I can tell you I am the least passionate person about that topic, but there was so much about it that I didn't even understand until like the team members came and started talking to us about like how, we want to decrease the patient's discomfort and it really does benefit them in this. And like, it was enough to sell everybody. And, I can tell you, I still don't love talking about that particular topic, but I understand why they embarked on that particular quality initiative. And I was happy to be involved after that, as were the nurses. So even without the protected time and, without time off unit to do a lot of that stuff, people got creative about how they could participate.
And I think people mentioned this too, but I think that whole, like, taking your data and actually sharing it, like once you find that thing like you're passionate about and you want to improve, it's great that you've changed things. But a lot of us function in, I think everybody who's talked today functions in a larger healthcare system that has central sites or outreach sites or is part of a larger network. And if nobody's hearing about what you're doing, getting administration to buy in so you can get some of those lasting changes made, like the clinical care guidelines or the order sets that just make it so easy when that septic kid comes in that you can just click a button and all of that bundle of care is automatically ordered. Like getting the resources to do that, you have to present information. And I think that has helped kind of get you on the map and get yourself seen or your project seen as something that can move forward and be successful. And people want to get behind and support. So I think that there's always that amount of like, I'm doing this project and I have no support or buy-in or anything, but I'm passionate about it because it's going to improve this patient care. And then instead of just stopping once you've done that, but taking that data and sharing it at, like, a lot of places have local QI days or regional QI days, and sharing that information, even if, like, a lot of people talk about how the projects start really small, even if it's really small, present it, because, you know, somebody else is probably like, hey, that's a great idea, I can do that. And it also gets your information out there.
And Krystle, do you have anything to share? Oh, we might have lost Krystle. Okay, I think we lost Krystle. If you don't mind, I was just wondering your thoughts on how QI is all intertwined. As in my previous role, I served as a pediatric quality coordinator, a PEC. And you know, one thing that I kind of learned is a lot of times I was focusing in on the nursing side of things and our process improvement and everything. And we can get wrapped up and really silo what we're looking at. So what are some of your best practices or tips, tricks, resources that you utilize to look at QI more broadly? So take, for instance, as you know, Dr. Corboy and Dr. Koopmans talked about, you know, the sepsis. You know, how are you looking at it as how you're meeting certain metrics, but how you can also look at and audit how often are we utilizing our treatment guidelines to ensure we are practicing to those evidence-based guidelines? And so you're looking at it not only from the nursing aspect, but you're looking at it from the provider aspect, and then being able to share all of that back. Can you guys speak a little bit more to how you implement that within your hospitals or your QI activities?
I can start with that one. I think, you know, the most important part of QI is your team, right? And making sure that your team represents all of the stakeholders that are involved in that particular, you know, whether it's a clinical process or a administrative problem or an actual, you know, kind of physical process of like getting something from point A to point B. You really can't understand the problem unless you talk to all the people that problem touches, right? So the, you know, taking it back to the model for improvement, you know, like what is it that you're trying to do? Like really the biggest question is, what is your problem and what would this kind of process look like if that wasn't a problem, right? And who does that problem affect? So making sure that you have a stakeholder representation from all of those people really gets you to answer those like 5 whys. Like, you know, why does this happen? Why does that happen? Like, what are all the barriers that are contributing to your problem and how are you going to improve it? And then, you know, you can have that smaller group of stakeholders, but then, you know, each of those stakeholders is representative of a larger group, right? So you have a nurse on your project, they're going to be responsible for sharing that with everybody in their discipline. You have somebody from EVS, right? You've got a throughput problem. So, you know, one of the members of that team are people from environmental services who clean your rooms and help you with that turnover to make that patient process move smoothly. Like, you can't improve your throughput if you're not talking to every single member of that team, right? And all of the stuff that you find has to report up to leadership, because change can't happen at that sharp end of the needle, right? You can improve small processes, but in order for those to be cemented and supported, you really need some kind of ladder, some process to feed that up to leadership. The people who decide like what they're going to invest in are really important members of that team as well, even though they might not be at that sharp end doing that improvement work. It's really important that they understand it and that they also have a stake in that as well.
Jackie, can you talk to some to like we have several when we're downtown anyway, there's a lot of order sets. We have them in the community as well, but because we're such a small piece of the larger pie, the pediatric services we provide, it's really tough to get analytics. But I think downtown they track if the order set's being used, right?
Yeah.
So you can look at that. And like if let's say you have like a bundled approach that you want and you notice like people aren't using the order set, why aren't they using it? Are they like smart list people? Can you make it? That's something we do a lot in the community because a lot of the adult docs do smart lists instead of order sets like we do at Lurie. So it's trying to figure out like you can get that information from your data team and they can look at that if you're using order sets and kind of help you know like what was the utilization. You used the order set 15 times but you had 700 patients with DKA. Why is the order set not being used? And then kind of starting there and talking to the people who are involved in it, like, well, that order doesn't come through to the nurse so she doesn't see it, it's a waste of my time or whatever it might be. So those are ways you can like concretely on the ground follow over time what's happening and look for areas of improvement.
Yeah, I totally agree. I was going to echo that exact thing. Interprofessionality cannot be underscored enough, but also being curious about other workflows is so key because we may think we understand how someone is accessing a list of policies. For example, you can have the most beautiful DKA or septic policy in the world, but if your docs don't know where to access it or it's not easily accessible, they're not going to reach for it. And so just something as simple as like creating maybe a table of contents of the policies that are up to date that we want our docs to be using, for example, is something we're looking at my institution, is key. And just something as simple as a list of, hey, this is what we should be doing. If X, then Y, and here's where you access it. Here's who you can call for help with it or whatever the situation is. So people aren't tasked with then, oh, I know I got an email about that a couple months ago and let me find that attachment, et cetera. But really understanding how to make it easy for people is a good way to enact a broader change.
Yeah, we just developed a steering committee for our clinical care guidelines at Lurie. They're pretty voluminous, right? In the emergency department, we have 70, and throughout the hospital, there's close to 200 clinical care guidelines. And, you know, we wanted to make sure that everybody knows where they are and that they are all up to date and, you know, they're guiding you to do things that the evidence still supports, right? So we developed a steering committee where, you know, the first 6 months was just kind of going to every different division and department saying, do you use clinical guidelines? Where do you house them? What are they? Can you share them with us? And we put them into a larger repository and we started going through them and updating them as part of EMSC. I know that Kelly just audited us and saw what we're building, but you know, all of those guidelines now have identifiable teams and leaders, and we're tracking important measurements and metrics on each of those things to make sure that they're still doing what they were intended to do. And that every at least 5 years, we're going through and making sure that things didn't change. I mean, you know, just think everybody on this call is probably clinical, but, you know, some of the practices that you did 5 or 10 years ago have changed. So, you know, like if you're still bolusing kids with insulin with DKA, that practice stopped, you know, a number of years ago. So if you're not updating your policy, you're still, you know, utilizing outdated kind of information. So it's really, really important that, you know, when you make these changes that you build into it some sort of framework to go back and reassess them periodically to make sure that you're still doing the right things and that process is still doing what it's intended to do.
Absolutely.
The same,
Great point.
and the same holds true for like order sets. So if you do build something within your electronic medical record, there needs to be a system in place that it's not like made and then just forgotten about like an orphaned child. Like every couple of years, go back. Is that order set still ordering what we want? Is it still ordering the right dose, the right administration? Because as the institution changes and the formulations and things like that change, or the even lab tests change, things get lost and things get changed. And if there's not some mechanism in place for those order sets to be continuously reviewed and made sure that they're up to date, they're going to become obsolete and not helpful to the end user. And so the efforts you've put in to make them and get them in place so that the right things are happening are going to kind of fall or fade over time.
Excellent point. Okay. As we wrap up here, I just want to start off again by thanking all of our presenters, as well as thanking everybody for joining us this evening. Okay, hold on. Yes. Okay, so just to refresh and wrap up as a reminder, whenever you are going back in to get your credits, do your evaluation, make sure that you are clicking in the login in the upper right-hand corner. You'll go to the Children's Minnesota Education and Training login section. Make sure you've got your your profile set up. Participants, you'll be going to that visitors login to set up your profile. Sorry, I spoke faster than the slide went. My apologies. Okay. Then generating your certificate. Again, just a reminder, attendance tonight does not automatically grant you credit. You do need to claim your credit and print your certificate. So you're going to continue to follow the course outline after recording your attendance and completion. You have to do this within 30 days of the conclusion of the event, and the course closes 30 days with no access after it. Your course will be listed as pending until you complete your evaluation form. And then once you have completed your evaluation, you can find that in completed activities and download button to print your certificate. If you do not log in to your Children's Minnesota account right away, you will get a reminder email that you need to complete your evaluation. Again, I'm stressing this a lot. It must be completed within the 30 days of the symposium in order to receive your credit. After that, you will no longer have the option to get credit. As always, if you have any questions, please do not hesitate to reach out to your EMSC state program manager with any concerns or questions. Thank you for your time and participation today. Lastly, if you would like to become a PEC or pediatric champion for your hospital, let us know by including a comment in your survey with your email address. Your state EMS program manager will follow up with you, or utilize the email addresses listed here on the slide and email your state program manager. Thank you. Oops, sorry. Thank you all very much. And we will remain on in case there's any other questions.